Hello and welcome to the second part of your infection induction. I'm Dr. Sahota, consultant in infectious diseases, and in this section we'll be talking much more about antibiotics and how to use them properly. So in the first part, we focused very much on identifying the patient with infection. So the key things being a good history and good examination, and other things like the appropriate investigations to use. Of those of you who will go onto IDU, I'll go into this with you in more detail. We talked about how you acquire infection in terms of the source, the route, and also the consequence of infection. We talked in detail about sepsis recognition and management, and I'm hoping that this gave you a holistic approach when you're thinking about the patient with infection. In this presentation, we'll be talking much more about antimicrobials. I'm going to focus on common antibiotics and give you a bit of a grounding in which antibiotics to use and when. I'm not going to talk in much detail about any other antimicrobials such as antivirals or antifungals, and I'm going to stick to the objectives that you have. And at the end, we'll go back to that first patient we met in the initial talk, and we'll see if we can bring all of these things together in managing that patient's clinical presentation. So hopefully you'll be aware that there is an antimicrobial app which is based on the UHL antimicrobial website. This is free for you to download, whether you're using Android or iOS. You basically go to the App Store, go to RX Guidelines app, download this. In the settings section, you'll see Manage Guidelines. You go to the antimicrobial section of that and pick UHL as your trust. So this basically has a summary of all the antimicrobials that you would otherwise find on our intranet website. It'll be useful when you're on the wards and want to refer to some information, but also if you're in DGHs, it'll be really helpful for your revision. So although most of the antibiotics we use will be very similar across trusts, there may be some subtle differences. So when you're coming to exams, you may have an OSCE which requires you to prescribe an antibiotic, and I would go back to the RX guidelines or the UHL guidelines in terms of your revision. So here I've created you a table of common antimicrobials, and we'll base the next section on this. So when you're choosing an antibiotic, there are a few factors that come into mind. Once you've decided that you definitely need one, there is definite evidence for infection. The first is that it needs to be the narrowest spectrum possible, and this is to prevent antimicrobial resistance, which we talked about in the first talk. And next, it basically needs to be the simplest to use. So this will include things like the route that you're taking, so whether it's oral, IV, subcut, intramuscular. Clearly, an oral antibiotic will be more logistically easier for both the patient and healthcare workers, but it may not be appropriate, for instance, if they've got sepsis. Once a day usage will be better than 3 or 4 times a day administration in terms of practicality. But again, certain antimicrobials must be given at higher frequency to maintain the level that you need them to be therapeutic. The therapeutic window is really important as well. So for some antibiotics, you need to measure levels very frequently to make sure, one, that they're in the therapeutic, have their therapeutic effectiveness, but also that they're not causing adverse effects. Drug-drug interactions are going to be really important. So what else is that patient on? Is this antibiotic compatible? And are there any worrying adverse effects, particularly things like C. diff risk? Cost is important, although probably at a sort of smaller level. We would clearly want to use the cheapest drugs available. That's better for the NHS. But it will be not as important as effectiveness and safety. And what are we aiming for? We want to prevent antimicrobial growth, whether that's by halting the growth or by killing the bacteria themselves. And this is basically based on the MIC, the mean inhibitory concentration, which is the lowest concentration of antibiotic required to prevent the growth of bacteria. And this is what you get from that sensitivity or susceptibility data from the lab. But just bear in mind, a lot of human factors can affect what you find in the lab. So things like weight, the patient's weight, their renal function, the burden of disease they have, and also the degree of inflammation. So we know, for instance, that some antibiotics will get into the meninges only when they're inflamed, but others will be able to penetrate the CNS regardless. So if we go to the antibiotics themselves, I would suggest you think about them when you're making a choice, betalactam versus non-betalactam. And that's because betalactams encompass all of the good points that I've just mentioned. So if we think about betalactams, they have the commonality is that they've got this beta-lactam ring. And this ring binds to an enzyme called transpeptidase on the bacteria, which prevents cell wall production. And this is basically by interfering with peptidoglycan cross-linking. So the simplest beta-lactam are the penicillins, and the simplest penicillin is benzyl penicillin, which is intravenous, and the oral equivalent would be penicillin V. And there's also flucloxacin. So these are narrow spectrum. They work really only on gram-positives, but they don't work on MRSA. So some bacteria have acquired a resistance gene called MEK-A, which basically means that they bind to penicillin. And this confers resistance to pretty much most beta-lactams. So it's worth remembering that when you're thinking about MRSA, you can't really use the commonly used beta-lactam antibiotics. And in terms of broadening that spectrum, you can actually add chemicals to your penicillins. So when you add clavulanic acid to amoxicillin, you can broaden its effect, which means that it actually covers also gram-negatives. So remember, clavulanic acid is a beta-lactamase inhibitor. So some bacteria produce beta-lactamase enzyme, which breaks down the beta-lactam ring. But if you have an inhibitor there, you can prevent that effect. Tazocin is similar, so you've got piperacillin with tazobactam, and tazobactam being the beta-lactamase inhibitor. And tazocin in particular is very helpful, it's a very useful drug, it's very broad spectrum, it covers gram-positive, gram-negative, and Pseudomonas as well. But remember, not MRSA. Then you've got your cephalosporins, and there's a variety in generations from narrow spectrum to broad. Ceftriaxone intravenously is one of the broadest spectrum. It covers a whole host of gram-positives and gram-negatives, and it's once a day, so it's a really helpful antibiotic which you can give in hospital and out of hospital. But it doesn't cover for MRSA or extended spectrum beta-lactamase producers. And then you've got your carbapenems, which are really our big guns. So this includes meropenem. These are extremely broad spectrum, which includes gram-positive, gram-negative, anaerobes, and also ESBL, which is why it can be very helpful. Because it covers so much, we often use it for sepsis management. So it's often the first antibiotic we use for sepsis, but we must narrow it down as quickly as we can to prevent resistance. And again, carbapenems do not cover for MRSA. One thing to be aware of with penicillins is allergy. So penicillin is probably the commonest drug allergy out there. It's reported to be present in up to 10% of the population, but when you actually delve down deep, most patients won't actually remember what their allergy was. And it's just something that they've sort of been told over many years. So it's really important to actually ask and see if there is a specific reaction that they've had. There is 10% cross-reactivity with cephalosporins, so you may want to avoid it in certain situations. And there's 1% cross-reactivity with carbapenems. So I would say most of the time, if there's a labeled penicillin allergy, you can safely use carbapenems. However, if you know that there is definite anaphylaxis to penicillin, you should really avoid all beta-lactam antibiotics. And then after that, you've got your non-beta-lactams. And in general, these all work by inhibiting bacterial protein synthesis in some way or affecting bacterial metabolic pathways. So you've got your macrolides, which include erythromycin, clarithromycin, azithromycin, and these are really fairly broad spectrum as well. They cover gram-positives, gram-negatives, and they also cover those atypical respiratory pathogens such as Mycoplasma and Legionella. So again, very helpful. Mostly come in the oral form apart from clarithromycin. There are a few things to be wary of. They can cause QT prolongation, which can lead to Torsades de Pointes arrhythmia if you're not careful. So if you're going to have somebody on long courses of this, you will need to do some ECG monitoring. And of the antibiotics, this is probably one that interferes with warfarin metabolism the most, so you really need to keep an eye on the INR when you've got somebody on these in warfarin. Fluoroquinolones, so again, these inhibit bacterial DNA gyrase or topoisomerase enzymes, which inhibits DNA replication and transcription as well. So you've got ciprofloxacin, which is really good with gram-negatives, including Pseudomonas. It's the only oral drug we can use to combat Pseudomonas, which is very important. And it's got really good oral bioavailability. So the bioavailability from taking a tablet is the same pretty much as giving it intravenously. It gets into all compartments of the body really well. And then you've got your newer fluoroquinolones, which include levofloxacin and moxifloxacin. And these, again, have a much broader spectrum. So they do cover Pseudomonas, although not quite as well as Cipro, but they cover gram-positives, gram-negatives, and those atypical respiratory pathogens that we mentioned. So they're really good oral treatments. If you don't need to give someone IV, you can send them home on these. But again, they can cause QT prolongation, so you need to think about those. There's also the risk of tendinitis, so you need to ask your patients if they're getting any tendinopathy type symptoms. They can decrease seizure threshold as well. And more recently, there's been a caution that quinolones can actually increase the risk of aortic dissections and rupture of aneurysms, so we have to be a bit more careful in using in vasculopathic patients. You've got your tetracyclines. Now, doxycycline is probably one of my favorite antibiotics. It's very versatile. It covers mostly gram-positive, but also some gram-negative bacteria. It covers your atypical, so it's sort of our go-to when it comes to treating community-acquired pneumonia and also in penicillin allergy. It also covers a lot of your fever in return travelers. So rickettsia, some malaria, particularly in the prophylaxis, you can use this, and falciparum in terms of joint treatment, and also spirochetes like Lyme disease and leptospirosis. But there are some issues, so you have to think about and tell the patient about photosensitivity. So they must make sure that they're not exposed for long periods in light. They use lots of sun cream, and in some it can actually cause a bit of esophagitis and swallowing problems as well. Also, we don't give it to children or in pregnancy because there's the risk of discoloration of developing teeth as well. And again, this antibiotic binds to the ribosomal subunit, so it prevents protein synthesis. Metronidazole is really the only important antibiotic in this nitroimidazole group. And this is really key because it's the oral and IV agent generally of choice when you're treating anaerobic infections, particularly things like C. difficile. But it's quite versatile. It also treats parasitic infections, particularly some amoebic infections, so a helpful antibiotic to give. Now, again, some cautions. It can, particularly with long courses, cause a peripheral neuropathy, so you need to make sure you don't give it for too long, probably 3 to 4 weeks maximum. And if you give it with alcohol, it can have this disulfiram-like effect. So it can give you sort of the effects of this disulfiram, which is flushing and tachycardia. So you would normally tell the patient to not take alcohol when they're on metronidazole. You've got your aminoglycosides, and the commonest that you'll come across is gentamicin. So this is, again, a really, really good gram-negative covering antibiotic, and it also covers Pseudomonas. So it's a very good one for that. It penetrates really well, but you can only give it intravenously. Amikacin is the other one, but this is really mostly used for TB, and you hold it in reserve for other infections. But gentamicin has a narrow spectrum, narrow therapeutic window, as well as being narrow spectrum. So you need to measure levels. It can cause ototoxicity and nephrotoxicity. So you'll see that on our wards, we have an actual gentamicin prescribing chart, just like we have for vancomycin. You may have heard of an antibiotic called clindamycin. This is not a macrolide. It's a separate group called the lincomycins. It can be given oral or IV. This is a very good antibiotic for gram-positives and anaerobic infections. So it would be your choice for, let's say, somebody with severe soft tissue infection who has necrotizing fasciitis. Really good for that. It'll cover your staphs and your strep. And actually in group A strep, it has an antitoxin effect, which is really good. And again, it prevents protein synthesis, just like the others. We have to be cautious, though. It can cause GI side effects, and there's a higher risk of causing C. diff with clindamycin as well. We come on to the glycopeptides. So you'll have heard of vancomycin. There's another drug in the same group called teicoplanin. So these, like the beta-lactams, inhibit cell wall formation, but they do it in a different way to the beta-lactams, which is why we will use them in beta-lactam or penicillin allergy. Vancomycin is really quite good. It's a good antibiotic. It does penetrate fairly well, but you do need to measure levels because you can end up under treating someone and potentially cause nephrotoxicity as well. Teicoplanin is a little bit easier, similar drug, but you only need to give it once a day. So it's got a wider therapeutic window. Levels need to be measured, but only weekly. So we use this quite frequently in outpatient treatment of patients who definitely need teicoplanin. These only cover gram-positive antibiotics, remember, but they're great for MRSA. They're our treatment of choice. And then there's a group of a few others which you'll have heard of and you'll come across. So we've got daptomycin. This is not the same group as vancomycin. It's a lipopeptide, and these actually interfere with protein cell membranes. Again, great for gram-positives only and MRSA. So another choice. You've got that in your arsenal for MRSA. It can cause myositis, like a rhabdomyolysis, so we need to check CK, creatinine kinase levels, weekly. You'll have heard of nitrofurantoin. Again, a really good antibiotic for lower UTI, covers some gram-positives and gram-negatives, including E. coli and Klebsiella, but you can't use it if you've got renal impairment, and you can't use it in pregnancy as well, and it's not good for pyelonephritis. It doesn't get into the kidneys very well. Trimethoprim, which is a dihydrofolate reductase inhibitor. So if you remember that this basically prevents the bacteria from metabolizing folic acid, which it needs to grow and reproduce. Very good for gram-negatives, again, such as UTI. And if you combine it with sulfonamides, which work in a very similar way, you broaden the spectrum. So you can cover some gram-positives as well, and you can cover some more unusual infections like PCP, which HIV patients get. And finally, you might have come across linezolid, which is the first in its class of these oxazolidinones. Again, this inhibits protein synthesis. It's a really good oral option for gram-positives, including MRSA. Very good bioavailability, very similar to giving it intravenously. So we do use this fairly frequently. However, it's a weak MAOI, so monoamine oxide inhibitor. So you can't use it if the patient's on other antidepressants because it can cause this serotonin syndrome. And also if you give it for too long, particularly over 3 or 4 weeks, then it can actually start to suppress your bone marrow, you can get anemias, leukopenia, and you need to monitor somebody who's on a longer course with regular blood tests. And it can cause a peripheral or optic neuropathy. So you'd always ask about those symptoms. So this gives you hopefully a nice overview of the antibiotics that we use fairly commonly. And you will now if we move on to when you use them, hopefully this will all make sense. So skin and soft tissue infections, we went through this last time, caused by staph and strep, particularly group A strep and Staph aureus. So what's your first antibiotic? Your narrowest spectrum, fairly easy to give. It would be Flucloxacin. For the streps, you can use something even narrower, which is benzyl penicillin. Remember, benzyl penicillin does not cover Staph aureus. So for Staph aureus, you would have to give Fluclox, but thankfully Fluclox also covers most of your skin and soft tissue streptococcal infections, like group A strep. Coagulase negative staph, if you remember, these don't tend to cause infection. If you find it, it may well be a skin contaminant. However, if you find coagulase negative staphylococci on sterile sites, so if you're taking lots of samples from an operative area like a prosthetic joint and you grow it frequently or recurrently, then it's probably relevant. And there's different resistance patterns. So some of them are Fluclox sensitive, some of them are resistant. So you'll have to look at that specific pattern and get some micro advice. And remember that coagulase is an enzyme which we really only detect in the lab, and it's the coagulase test which will differentiate between Staph aureus and other staphylococci such as Staph epidermidis. In penicillin allergy, you can use all of the other things I mentioned earlier that cover gram-positive. So doxycycline is probably our go-to. You can use clindamycin. You can use levo. And if you need to give intravenously, you can give ceftriaxone and, dare I say it, meropenem as well. For MRSA, generally, our go-to IV therapy is vancomycin. But you can also use teicoplanin or daptomycin, which are, again, IV, or oral linezolid, but taking some caution. And musculoskeletal infections, exactly the same as skin and soft tissue, pretty much. So you're more likely to get your Staph aureus and streptococci. So it's the same antibiotics as above. Just be wary of things like diabetic foot infections, which can get colonized with your Enterobacteriaceae or Pseudomonas, your gram-negatives. And for those, you must think broader spectrum. So there may well be some resistance in there. So you might, at this point, want to use your broader spectrum penicillins like tazocin or possibly even carbapenem. But you will be guided by your samples and the sensitivities on those. I put TB in here because we do not fairly frequently find bone and joint infections caused by TB, and you must have some awareness of the TB drugs as well. Respiratory infection, so you should know now that the common pathogens strep pneumoniae, Haemophilus, influenzae, these will thankfully all still be treated by your narrow spectrum penicillins, amoxicillin, benzyl penicillin, although there is some increasing resistance to benzyl penicillin, so just need to be a bit wary of that. Atypicals, again, we've talked about which cover, doxy, clarithromycin, levofloxacin. Viruses I've stuck in there, but the only real helpful drug we have, antiviral, is oseltamivir or Tamiflu against influenza. GI, again, let's think back. So viruses, ignore those, but if you do have bacterial infection, it will be your Enterobacteriaceae. Commonly things like Campylobacter, Shigella, certain strains of E. coli. You may not need an antibiotic at all if it's mild, but if they are more severe or even systemic infections, then a fairly narrow spectrum oral antibiotic like ciprofloxacin should be fine and can be given at home, or azithromycin as well, remember the macrolide. However, if they've got severe systemic infections, such as with Salmonella typhi or enteric fever, then you must give intravenously initially, and that would be with ceftriaxone or azithromycin. And I'll talk more about that in my fever and return traveller talk. C. difficile is a specific sort of special case. You give oral therapy. First line is metronidazole, but you can also give vancomycin orally in more severe disease. And remember, this is probably the only time you would give oral over IV in severe infection. If you get more visceral infection, so that's liver abscess, splenic abscesses, pyelonephritis, that kind of thing, or peritonitis, for whatever reason, then you need to cover your Enterobacteriaceae, but you also need to cover your anaerobic bacteria as well. So generally speaking, the narrowest spectrum you'd probably be able to get away with is coamoxiclav to cover all of those things. It has some anaerobic cover as well. You could give Cipro with metronidazole, because then you've got your gram-negative and your anaerobic cover, or gentamicin with metronidazole, or you go straight for tazocin. So tazocin will cover, remember, your Enterobacteriaceae. It's got some gram-positive cover just in case. It covers Pseudomonas. It covers your anaerobes. And it's 3 times a day, so it encompasses it all in one. But it's not narrow spectrum. So you just need to balance those things out. If there's penicillin allergy or you suspect ESBL, you'd probably have to go for meropenem. GU tract, again, most UTIs are going to be caused by your Enterobacteriaceae. 50% of the time it will be E. coli, and then a mixture of Klebsiella, Proteus after that. So if it's a simple lower urinary tract infection, you can get away with nitrofurantoin or trimethoprim. And that's nitrofurantoin is UHL's first line at the moment. And this changes sometimes because of the sensitivity patterns in our community. So it may be different in the trust that you're working. But you can also give ciprofloxacin if it's slightly more resistant, or coamoxiclav. So UTIs are one of those where you really have to look at the sensitivities, get a sample sent for culture, because you may get caught out by assuming that everything is going to be nitro or trimethoprim sensitive. Occasionally you can get Pseudomonas causing these infections, and the only oral agent, remember, is ciprofloxacin, or you might need to give intravenous therapy with something like gentamicin or tazocin. Be wary of ESBLs increasing in frequency, and the only real option we have there is carbapenem. Occasionally we can use another antibiotic called fosfomycin. Gonorrhea is again a slightly separate case. Lots of resistance, so we end up giving either intramuscular or intravenous, usually ceftriaxone. Chlamydia, again, you can use azithromycin or doxycycline. A few other ones to finish with. So CNS infection, your common bacterial meningitis, strep pneumoniae, Neisseria meningitidis. So there's a lot of resistance to this now. Penicillins used to work well, but there's a lot of penicillin resistance, particularly benzyl penicillin. So although if that's all you've got in the GP practice, you can give that as one stat dose IM, but when you get to hospital, you should be giving a more broad spectrum cephalosporin, so either ceftriaxone or cefotaxime. So remember, these get into the CNS really well. They're broad spectrum. They cover both these organisms and probably a little bit more than you need. But it's the CNS penetration that's really important, which is why we give these. Haemophilus influenzae occasionally, and that'll be covered by ceftriaxone as well. Now, one other caveat, strep pneumoniae, one of the problems with getting this as a meningitis, it can cause a lot of other neurological sequelae, including deafness. By giving dexamethasone at the same time as your antibiotic, you can reduce that risk. Another special case in CNS infection is listeria. So remember, age over 55 or in the immunocompromised, meningitis you must cover for listeria. Now, listeria will not be covered by ceftriaxone, so you add in amoxicillin. So it's fairly high dose, high frequency. You'll be giving it every 4 hours, so it's quite disruptive to the patient and to the staff. So if it becomes very difficult, our very useful meropenem, thankfully, will cover all of those organisms, including listeria. So you just have to change the dose a bit. But just remember amoxicillin for listeria. We do get TB causing CNS infection, clearly a different kettle of fish, but be aware of the drugs you should use. And the only virus I want to mention to you that can cause encephalitis is herpes simplex. Do not forget this. So particularly in the older patients, immunosuppressed, grumbling sort of infective symptoms and focal neurology, it may well be HSV, and you would want to add in IV acyclovir to that cocktail and then sort it out based on the LP results. Endocarditis, I won't focus on this too much, but commonest organisms are your streptococci, in intravenous drug users, Staph aureus. You may get enterococci causing it as well. And generally speaking, Fluclox for Staph aureus, Ben-Pen for strep, amoxicillin for enterococci. If you really don't find an organism, then ceftriaxone is a good one because it will cover all those organisms fairly well and a few others too. And if they've got, again, MRSA or pen allergy, then vancomycin and potentially tyke or dapto are okay as well. Line infections, so you know this already. So it'll be the same, your Staph aureus, potentially coag-negative staph, and some of the streptococci. So you'll use the same antibiotics as above. Just be aware of MRSA because you may need to give vancomycin, and some of the coagulase negative staph are not sensitive to Fluclox either. So it all depends. But the key thing is get that line out if you don't need it. And then that leads me on to other hospital-acquired infections, particularly in areas like ITU, where people have been getting a lot of antibiotics. So you're thinking you're more resistant Enterobacteriaceae, you're thinking Pseudomonas, which is an opportunistic pathogen, possibly C. diff can happen as well. So generally speaking, you'll be going a bit more broad spectrum, but you'll be guided by the sensitivities from whatever specimens you've sent. So you may end up needing to give tazocin or meropenem here. So that's antibiotics in a nutshell. You can always refer back to these tables. I'm not expecting you to memorize all of that right now. I'm going to move on to a 10-point approach, which I think is really helpful when you're thinking about or potentially taking a history or managing an infected patient. And you can use this going forward any time. So the first thing is, what's the evidence for infection? Now, we've gone through this already, haven't we? What additional questions will you ask about in the history to know if this is infection? And what will be in your focus examination? And could there be any non-infective differential diagnoses? That's important too. Second point, which investigations would you request? Are there any bedside tests you can use, any blood tests? Which microsamples will you send, whether it's a swab, whether it's a blood culture, an LP? And will radiology help you at this point? So think about all of those when you're thinking about your investigations. Number 3, how severe is it? Is it mild infection, moderate, or severe? And think about severity scores. So red flag sepsis is one, but you'll have heard of Curb 65 for pneumonia. This will help you decide what route you're going to give your antibiotic, how aggressive you need to be with your therapy, whether you can send someone home or not. Are there any patient factors to consider? So think about comorbidities, immunosuppressing drugs, the patient's age, their gender potentially, and also their social circumstances, which may lead to certain infections or more severe infections. Point 5, which body system or organ is infected? Hopefully by the time you've come to point 5, you'll have found that out. There'll be some clue that will tell you. And then, which microorganism? Now we've spent so much time on this already, you should know which microorganism or organisms are much more likely for, let's say, skin and soft tissue, bowel, and in CNS, for instance. You'll have a good idea now. Point 7, which antimicrobial therapy is best? We've gone through this in detail and that table, and by which route, IV, oral, or other. Point 8, is any other treatment needed? So you're thinking now sepsis 6 management, supportive therapy, fluids, is surgery needed for source control? And also think, what am I going to do with the usual medications as well? Do these need to be changed? Number 9, is there a risk of transmission to others? So we always have to think about this. So what measures will be needed to prevent this? Think of PPE, think about where that patient should be managed. And finally, once that patient is better, what planning is required for follow-up and discharge? So you'll be thinking things like, can I now narrow the spectrum of the antibiotic? Can I switch to oral? Can I stop them altogether? Are there other members of the MDT that need to be involved to help me get this patient home? So let's go back to our case. So we've got our older lady referred by her GP into AMU. She's presented with a swollen, painful leg for the last 3 days. But for the last 1 day, she's been feeling much more unwell, febrile, breathless, lethargic as well. She's got type 2 diabetes and rheumatoid arthritis, and a couple of weeks ago, she had a total knee replacement for osteoarthritis. You go through her drugs, she's on prednisolone and methotrexate, and she's got an allergy to penicillin where she gets a rash. So you go to see her. These are her obs and parts of her examination. So she's febrile at 39 degrees. Heart rate's 132 beats per minute. Blood pressure is 88/65. Tachypneic, although chest sounds clear and SATs are okay. Abdomen feels soft and non-tender. Neurologically, everything seems fine. She's chatting away to you. GCS is 15. The nurse brings you a urine dip result, which shows 1 plus a protein, 2 plus a leukocytes, and negative for nitrates. And you look and examine her top to bottom. She tells you that she's got a painful leg, and you look at her foot, and this is what it looks like. Okay, so I'll let you digest all that information. So if we go back to our 10-point approach, what is the evidence for infection? Well, let's see. What do we have? She's febrile. That doesn't necessarily mean that she's got an infection, but it's a pretty good indication. And look at the skin. She's got a red, hot, swollen foot, and there's maybe a little hole in there, maybe where she had a puncture bite, an insect bite, who knows. But skin and soft tissue seems to be the most likely place. And you haven't looked anywhere else yet, have you? I think, could there be a non-infective differential? We mentioned that there as well. So what do we know about her? She has had a knee replacement recently. So you need to look higher up as well. Look at the wound. Does this look obviously infected? Could this be a recent post-surgical infection? Is the wound dehiscing? Could there be an abscess in there? Does this need surgical exploration? What else could cause leg pain? DVT. So that can sometimes cause fever, and obviously it will cause leg pain as well. Just make sure it's not something obvious or something else like a DVT, where you need to actually do a venous Doppler scan. Which investigations would you request? So you're going to be thinking about your standard blood tests at this point initially, aren't you? So we go back to any bedside tests, blood tests, so full blood count, your differential white cell count. Is it neutrophils? Is it lymphocytes? Is there any chronic sort of anemia? What's the CRP? Is that raised? The higher the CRP, the more likely it is to potentially be bacterial infection, although it's non-specific. Platelets can go up in inflammation and infection as well. And, are there any other samples you'd want to send? So any cultures, for instance. So let's see what we've got. So a blood glucose is 25, a lactate is 3.2. You've got those parameters there as well. The CRP is 180, white cells 23, pretty high, neutrophils 17. So I would say altogether that's fitting more with a bacterial infection. So there are actually, some tests that are quite concerning there. What else are you going to do? You're going to do a blood culture, aren't you? That's probably the key thing you can send. If there's anything on the skin in terms of pus, potentially a deeper sample rather than a superficial sample, you could send that off as well. And clearly the knee, if it's if it's affected, you might need to get orthopedics involved to aspirate that knee to look for infection. So these are your key things. Check an INR, check your coagulation factors, because you can get a coagulopathy and sepsis. LFTs may be helpful here as well, particularly in terms of looking for markers of sepsis. But these are really your key things. How severe is it? Well, let's have a look here again. So you definitely have a sign of red flag sepsis. You've got your tachycardia, your tachypnea, and that systolic BP is pretty low. So I would say there's a concern here about severe infection. From the blood test, the lactate is high as well, so that's a concern in itself. And you've got an acute kidney injury. Urea's up, creatinine's up. Now, it's always worth just looking back, go back to any old UNEs you've got, and compare. This may actually be chronic kidney disease, particularly in diabetic nephropathy. So just make sure that it isn't actually normal for her. But if it is an AKI, then that's a concern that there's potentially sepsis, there's a hypoperfusion of the kidneys or vasodilation. So that would be a concerning factor for sepsis. Any patient factors to consider? So what do you remember? So if we go back to the history, she's older age, so weaker immune system. She's got the operation there. Type 2 diabetes, again, increases your risk of infection, possibly even diabetic foot infections. Rheumatoid may be relevant. Look at the drugs. Yep, she's on immunosuppressants, isn't she? So she's on both prednisolone and methotrexate, which are going to make her more at risk of more severe infection. So all these things are going to be relevant. Which body system or organ is infected? Well, clearly it's her foot, but it looks like it's not just her foot. This has become a systemic problem. There may well be a bacteremia here now as she's got sepsis, and a lot of her other organs are involved as well, aren't they? Her kidneys are involved. In particular, she's developing maybe a metabolic acidosis. You know, I haven't given you a pH at this point. Which microorganisms may be involved? Well, you know this now, yeah. Skin, soft tissue. So we're thinking Staph aureus, some of the beta hemolytic strep. So it could be group A strep. It could be any of the other streptococci that can cause the Lancefield group strep. So C, D, E. Any of those could be causing this infection. So when you're thinking about treatment, you'll bear that in mind. One other thing that I didn't go through just now, we talked about patient factors. What else is there that you're worried about? Blood glucose is 25. That's high. We'll come to that. Which microorganism? You know this now. So again, Staph aureus, we've done that. We've done the microorganisms. But which antimicrobial therapy is best? Okay. So Staph aureus, streptococci, what's it going to be? If I show you the table, shouldn't need to really. So it's going to be Flucloxacin, which will cover your staph and your strep. Is that okay? What else is in the history? Go back. Allergy to penicillin. She's got a rash. So what else can you use? Hopefully you'll be thinking about vancomycin possibly. It's intravenous. Now remember, she does need something intravenous. She's pretty unwell. She's septic. So that would be reasonable. But she also has AKI. So you have to be careful with your dosing. You can still give it, but you have to be careful with your dosing. And you'll need to measure levels fairly frequently because of the narrow therapeutic window. Other things you potentially could use. Some of you might be thinking, what about doxycycline? That would be okay if it wasn't such severe infection because you can't give doxycycline intravenously. You could think about things like clindamycin as well. There's a bit of a C. diff risk, or even something like levofloxacin. So there's a few options, but in our trust it would be vancomycin IV option, doxycycline oral if it was appropriate to give oral. Any other treatment needed? Now let me go back. So we've already mentioned the glucose. So she could have potentially DKA or HHS. So you'd want to bring that blood sugar down, wouldn't you? That could be problematic for her. So it could be up because she's got poor diabetic control and that's what's caused the infection at all. Or it could just be up because she's got sepsis. So either way, she needs intravenous insulin at this point, doesn't she? To bring that blood glucose down, which will also help with any metabolic acidosis. What else do we need to do in terms of other things? Let's have a look. You'll be doing your sepsis 6. You'll be giving fluids cautiously, improving that AKI. You've got a lactate, you'll be checking your urine output. You might need to give a pain relief. You're giving your intravenous insulin. Let's look at her regular drugs. So what did I say? She's on prednisolone, methotrexate. What are you going to do with those? Well, generally speaking, if a patient's on something immunosuppressing, you need to stop the immunosuppressant, right? So definitely with methotrexate. Prednisolone, would you increase it, decrease it, stop it? Now the problem with prednisolone is if you stop long-term prednisolone abruptly, you can cause a hypoadrenal crisis. So actually, it's counterintuitive. You do the opposite. You actually continue the prednisolone and increase the dose to prevent that hypoadrenal crisis. That's the only immunosuppressing drug that I wouldn't stop. But other things, generally speaking, you might need to get some advice about this from rheumatology, but generally speaking, stop the immunosuppressants. So they're the key things here. Is there a risk of transmission to others? Possibly. It could be MRSA. You might want to look back at some old results, any old swabs. But unless there's some evidence of that from before, then probably it is an MRSA. And you can manage this patient in a normal sort of ward-based scenario, ward-based environment. So you've given your treatment, you're giving your antibiotics, you're giving your supportive treatment, you're thinking about the wound, you're thinking about diabetic management, you're making sure that there's no abscess anywhere, anything that needs orthopedic follow-up or involvement, etc. So what planning is required for discharge? So eventually, hopefully within 24 to 48 hours, her signs of infection will be settling. You can repeat the inflammatory markers. You'll obviously keep an eye on blood pressure, urine output, etc. You've done your source control. Things are working. The patient's feeling better, and the OBS and everything are getting better. So you'd want to make sure that you think about stepping her down from intravenous to oral antibiotics. So here, doxycycline might be reasonable. You'd probably want to carry on for 5 to 7 days in a severe cellulitis. And eventually you would stop and you would tell the patient that they need to stop as well. Who else needs to be involved? So this is a multidisciplinary issue. So you need to get potentially the diabetic team involved. You may need to get orthopedics involved if there's other concerns about her feet. Vascular might need to be involved if there's diabetic foot complications as well. You might need OT, physiotherapy, and all of these things may be needed on discharge also. Okay. So in summary, we've talked about everything else before. We've brought it together in this case, but we've also learned about the appropriate use of antibiotics. And I know I've hopefully given you a useful 10-point approach to the patient with infection. I look forward to seeing some of you on my ward, and for the rest of you, very good luck for the rest of your block.